off. And with that, thank you, Amy. So good morning, everyone. This is Lisa Letourneau with Maine DHHS. This is one of many in our series of brief clinical info sessions about the COVID vaccine. I'm going to move to share screen and just start a brief PowerPoint presentation, being joined today by Dr. Stephen Sears and Dr. Laura Blaisdell. We're going to be venturing into issues of trust and vaccine hesitancy. And Dr. Blaisdell has done a tremendous amount of work on that. Many of you probably know her from her previous work around immunization campaigns, including the one just about a year ago. So this is going to be a brief didactic session. We do offer, through a great partnership with Maine Medical Association, a half an hour Category 1 CME if anybody wants that. We have changed the mechanism for that if you weren't on last time. So it's please send an email just to keep all the names and functions out of the chat to covidcme.dhhs@maine.gov. If one of my colleagues could copy that and put it in the chat as well, that would be great. Eventually you will get an evaluation form from the MMA and then CME reckoning in another few weeks or a month or two. We do not have any financial relationships, to disclose. And we have been sort of chugging along on a curriculum. This time we'll just talk briefly about the vaccines and safety considerations, and again, starting to dive more into issues of vaccine hesitancy and having conversations with your patients, knowing that the time is coming when the vaccine is going to be opening up a bit more to the next phase of populations, and I'll talk just a little bit about that. So with that, I'm going to skip over, and for those who may be new to the call, again, we've been having these twice a week now for, gosh, I think a month or close to a month. We have recorded one of these at least each week and put information on the website that I'll cite at the end, but we are purposely jumping over some of the issues of vaccine development and the science and the trials, only because we've covered it several times now. But with that, I'm going to turn it over to Dr. Sears and talk a little bit about the vaccines.
Great, and I will be very quick because, as Lisa said, we have covered most things several times. We're happy to take questions at the end if there still are questions about those things. So we really are in an incredible position because we have two vaccines that have emergency use authorization through the FDA. That's the Moderna, the Pfizer. They are very, very similar, and this just gives you kind of a side-by-side comparison. They're the same type of vaccine. They use mRNA. They're packaged up in a little bit of lipoprotein. The chemicals that package them are about the same. Efficacy is about the same. There's some differences in that Pfizer was used in 16 and older, Moderna only 18 and older, so those are just things to keep in mind. And probably the big one has to do with the storage components, in that the Pfizer vaccine needs ultra cold storage at -70°C, whereas the Moderna doesn't need, it just needs a regular freezer. Why is that? That's because mRNA is a very unstable compound. Left on its own, it will degenerate very quickly overall. Next slide. I think lots of questions about what's in it, what's not in it, how's it made. I think it's important to emphasize that this really is just a little bit of mRNA wrapped in some lipids with a little bit of salts and sugars and a little bit of polyethylene glycol. It is not a live virus. It does not contain thimerosal. It does not have mercury. It's not made in fetal cells, has no pork products. What you see above is what you get overall. Next slide.
I just want to point out, Steve, I keep adding to the list of what's not in it. As
I see. Sorry, I looked on the right hand. I only looked on the left. I didn't look on the right. There are no eggs and gelatin, latex preservatives, or GPS chips to track you. So thank you, Lisa.
Video going around that says it includes a GPS chip.
Oh, do not be very careful on what you see out there on social media regarding this. There are lots of frequently asked questions, but actually I'll go over a couple. But what we want is your questions at the end. Should you still have some that are not answered. Right at the moment, it is still recommended that we continue to wear masks and distance after vaccine. Why is that? Not everybody's going to be vaccinated. We don't know whether this vaccine keeps you from actually getting low-grade infection and being able to transmit. That's an unanswered question at this point. Hopefully we'll get answers to that in the future, and we'll get better guidance as we get more of the population vaccinated. If you're a close contact, it's still recommended that you quarantine, and how long after it do you get immunity? It probably the robust immune response is between 1 and 2 weeks after the second dose. Been lots of conversation about one dose only. One dose in both the trials was not really measured for long-term immunity. It was really measured as a marker, and it appears to be about 50% or thereabouts for each one of those with a fairly broad confidence interval. Does it mean if you've been vaccinated, you won't get COVID? We have actually seen some people who have gotten COVID after the first dose. It is much less likely that you will get COVID and much less likely you would get severe COVID after the second dose. That's what the trials showed overall. So I'm going to turn this over to Laura, who's going to talk about some of the aspects of how we can make sure that we talk about this vaccine and about some of the challenges of making sure people actually take it.
Actually, I'm going to jump in 1 second, Laura, if you can, just because I realize it probably makes sense to let people know when are you going to be having conversations with patients, right? Because this is really what we're talking about, or your colleagues. So I think it might make sense for us to talk about where we are in terms of the vaccination phases. So we are still in phase 1A, which is healthcare personnel and residents of long-term care facilities. The good news is we are marching through that, and I think as of last week, maybe we were halfway, a little more, and I think this week maybe closer to 3/4. The goal is to complete that by the end of January and then move on to the next phase. I will say these are the phases that were recommended by ACIP, American Committee on Immunization Practices, but it's up to each state to decide what they're going to do. I know there's been a lot of conversations about, well, maybe more older people should be in, et cetera, and those conversations are ongoing. And I expect that we'll be hearing more about what our next phases are going to look like as soon as this week. So your patients will be in line very soon. The goal is maybe by early February. So with that in mind, I'm going to go back to the good Dr. Blaisdell and let you pick it up from there in terms of issues of trust and vaccine hesitancy.
Great. Thank you so much, Lisa.
Maybe just introduce yourself a little bit more than I briefly did.
Sure. My name is Dr. Laura Blaisdell. I'm a pediatrician. I'm currently the vice president of Maine Academy of Pediatrics and have done both research and extensive policy work in vaccine hesitancy. So I think, first of all, given the amount of time that we have this morning, it will be a disappointing presentation on vaccine hesitancy because it is so deep and broad, and there are so many reasons for it. I think it's important to realize that we're not just dealing with vaccine hesitancy at this point, but we're also dealing with sort of an early adopter phenomenon. So, we need to be careful about what is true vaccine hesitancy and what is an early adopter phenomenon. However, the frequent concerns that we're hearing are just the speed of the vaccine development and the approval process, the difference between EUA full approval, FDA full approval and EUA, concerns about the new technology, which is in terms of using it for vaccination in large vaccine scales. There's also, of course, the issues of trust in the government process, kind of the personal versus community benefits. And I think it's really important that to note that there is exceedingly good reason for some of our Black, Latinx, Indigenous, Asian Pacific, and other communities of color for having concerns in the historical context of how the medical establishment has either protected or not protected some of these communities. So I think that's an important foundation for our discussion. So the Kaiser Family Foundation did a poll in late November, early December, and looking at the urban-rural divide. Of course, that's been something that's been looked at in through many lenses. But here we see that in an rural-urban divide, 30% of rural residents said yes, they would get the vaccine. 38% would want to wait and see, and then 20% are definitely not getting the vaccine. So here you see sort of that early adopter, late adopter, and perhaps true vaccine hesitant split. Next slide. So when we look at this slide, you again see kind of the dichotomy in rural-urban views about being worried about COVID-19, about the exaggerated nature of perceived exaggerated nature of COVID, and then whether or not they believe vaccine is a personal choice. Next slide. I think the most important point on this slide, once and again, people continue to cite their PCP or their healthcare providers as the largest source of trust on vaccines. So that is us, that is who we are, and we continue to have that trust of our patients. And it's the one time that I can say that I have more trust than Dr. Fauci. So, we have to use that trust. And when we think about communicating vaccine hesitancy, it's really essential to know that there's not one golden bullet for communicating, but we do have to use these trusted relationships that we have. And it's very important to continue to meet people where they are. So this means not less of, and if we can go to the next slide, less of talking at people or giving people information, trying not to say everything, but asking people where they are. What is it that's keeping you from wanting to vaccinate today? And so, I think why I bring up the point of early adopters is that many of us steel ourselves for conversations about vaccine hesitancy with a preconceived notion of why that person might be vaccine hesitant. And I really encourage us to meet people where they are, clearly explain the vaccination process hasn't been no steps in vaccine approval have been not taken in this vaccine. And I think the other aspect about safety that I think is unprecedented, sorry to use that word, in this vaccine is that we are rolling this vaccine out in millions of people. So our data acquisition, our post-market data acquisition is so great that it's unlike any other vaccine. We know very quickly if this vaccine does have side effects. So we can go 2 slides forward. I just wanted to give you some talking points for today, and then I will wrap up. There is, you can talk to people about the common good. Getting people vaccinated is the best and fastest hope to end the pandemic. About vaccine safety, about the large studies of the vaccine safety, and then the comment about how many people it has been given to. And I think it's important to say that you believe it is safe for your patients. When we balance the risk of getting the vaccine against the real risk of getting COVID, that might be a compelling motivator for some. I think it's important to talk about, your personal experience. I got the vaccines, my physician colleagues got the vaccines. I would give it to my kids, mother, partner, whichever it is that you feel that you can say there in terms of your personal statement. It's very compelling. And then, if you get stuck, then, explore those kind of persistent concerns. What data would convince you that the vaccine was safe? And where do you get your information, and what information has been compelling to you? And let's talk about it. We put up this slide about the myths, but the main point that have been coming up about the vaccine, but the main point here is that there is an active and concerted effort to create and foment uncertainty about vaccines. And that has been going on for quite some time, and it's continuing with this vaccine. So I think it's really important to know what the myths are out there. What can we do about it? We can know that they're there and be prepared to refute them to the degree that we can, and also try not to repeat them outside the context of the patient encounter. So we don't want to amplify the myth, but I think it's also important you can share with patients that there is a concerted effort to get myths into the ears of Americans. And so if they're getting their information off of a social media site or through friends, maybe to investigate that as well and talk about the issues of getting information that way. So passing it back to you, Lisa.
Great, thank you. Thanks so much, Laura. And sorry, we do have a short time. We want to open it up to questions, and again, we'll keep the conversations going. I mentioned the phasing, which is likely you will be hearing more soon on that. It's not necessarily going to be exactly this, so more to come. Lots of links and other information. We do post our recordings and slides on the CDC website that you can see here, and always happy to take questions afterwards. So I'm going to stop sharing and open it up. to questions that either have come in the chat or folks can feel free to unmute. Anybody, our little faculty group monitoring? Amy, you want to kick this off?
Laura, the first one is, what's the goal of people discrediting the vaccine?
The social political movements are broad. There are lots of motivators for various social movements. However, without going into it deeply, just to know that discrediting and creating disruption in our trusted institutions is part of that.
There's several questions, and I'm not sure we'll have the right people to answer this, about the federal pharmacy partnership with Walgreens and CVS, and just the delay around getting this clinic scheduled. I don't know if there's anyone on the call.
Yeah, Amy, I think unfortunately, we don't have a lot of details on that. So this is the Federal Pharmacy Partnership. Amy mentioned long-term care, Walgreens and CVS are the two big ones. I know there's been some delays, particularly with Walgreens. I would say if you're, whatever sector you're in, potentially try to touch base with either like the long-term care ombudsman or the Office of Aging and Disability Services, but we don't unfortunately have any more specific information about this. They're absolutely, that should be underway. I also see a question about, must be from assisted living, I guess, or congregate care, needing an order from a provider. That is the case, if there's a way to partner up with a provider to get a standing order for your facility, but the vaccine is a medication and does need a doctor's order. We don't have a statewide standing order because of issues related to vaccine risks. So yeah, it's you need to find either a doc or in several docs to work with on that, or providers, I should say. There's that you've been.
Another question, this may be for Peggy Panoia. How dangerous is PEG? Isn't this antifreeze talking? And I think there's been a couple of questions about PEG, and if there's been any more discussion around relationship to anaphylaxis.
So this is Peg Benoyer. The PEG concerns, it's a very rare allergy. In 30 years, I had seen one patient we thought might have a mild one. So it's very uncommon. We're not absolutely certain that's the reason people are reacting to this vaccine. However, it can be easily tested for with an allergist in patients who we strongly suspect have a PEG allergy, who have reacted to a vaccine that contained PEG or had anaphylaxis to a medicine that contained PEG. Otherwise, it's very uncommon, very low incidence. Reactions are just very uncommon. People get it in every medication. Does that?
Yep. And this may be for Dr. Sears and Dr. Panoia, but the second dose, people are reporting feeling sick for several days. And I think that was in anticipation the second dose might have more side effects. If either of you want to talk to that.
Sure, I'll just mention something quickly and then see what Peggy has to add. But basically, in the trials, it was clear that the second dose actually had a higher rate of adverse effects than the first dose. And those are, the headache, aches, pains, et cetera. Those are listed as lasting about 1 to 3 days. On typical, though, it's about 24 hours. We have seen some people who have had delayed reactions from the vaccine at the local site with large reactions 7 to 8 days later. I actually had a picture. I sent one to Peggy about that. And but that's also described in the if you look at the New England Journal of Medicine about the safety of the Moderna vaccine, it's described. It didn't happen all that often, but I've heard that as probably one of the things that people have sent to me more commonly.
Have a large reaction, delayed injection reaction. Is that a contraindication for getting the second vaccine?
That is not a contraindication if it's a delayed reaction, but Peggy, do you want to chime in on that one?
So yes, so it's not a contraindication. Those patients will go ahead and get their second dosage. The only contraindication would be having had an immediate allergic reaction of any type on the day of your vaccine.
Another question, Dr. Shaw mentioned.
An allergist, sorry, they should also.
Sorry, Peggy. Dr. Shaw mentioned if you receive the vaccine, you shouldn't have an antigen test done since it will be positive. Can you address?
Yeah, I'm going to get back to everybody on that because I didn't hear him say that. And the literature I've seen before has said that that's not the case. And I have to make sure there are lots and lots of different types of antigen tests, but the routine ones really should not be reactive from the vaccine you're developing. But as I said, if he said that, perhaps there's some updated information. He and I talk about that a lot, but thank you for bringing it to our attention, and I will see where that is and get that to the next talk.
Are there any issues with giving the vaccine to those who have recently had other vaccines like flu or shingles? What's the time period between giving other vaccines and COVID?
Yeah, in the trials, they generally had the individuals that had not had the vaccines, and they've delayed, and it's recommended to delay them by 28 days. If it happens to be you've had them, then it's not a contraindication of the vaccine.
Dr. Penoy, this is probably another one for you. Are there any new recommendations
Hey,
regarding
Amy, it's a little bit hard to hear you. I don't know if you can lean forward anymore.
Dr. Penoy, are there any new recommendations regarding people with other severe allergies who carry an EpiPen and get the second dose at the provider's office, or can they continue to receive the second vaccine at a clinic and be monitored for 30 minutes? For the second dose, severe allergies.
So if they've had a second dose, severe allergy, I'm sorry, Amy.
If they're going to get their second dose, history of severe allergies, carry an EpiPen, can they still get that in a clinic and be monitored for 30 minutes? Are you expecting any additional potential reactions with the second dose with someone with a severe allergy versus the first?
So only if they already carry an EpiPen should they bring their EpiPen to their visit as they would normally. They should carry their Epi everywhere, every day, always. They should wait 30 minutes as instructed. And there are a few contraindications to the only contraindication to a second dose if you react to your first, again, is you shouldn't get it if you've had a problem on the day, or you think you should first consult an allergist or immunologist.
I might start reading some of these. It's just a little bit hard to hear you. Will the state
I'm just gonna answer one because I'm glad somebody added it to the chat. You will have a positive antibody test. If that's what Dr. Shaw said, that is clear, but you will not have a positive antigen test because that is a different thing, a different moiety that's being recognized by the rapid antigens. And I will, as I said, the only thing is there's about 20 different antigen tests on the market, and I'll sort of do a quick research and make sure there's none of them that cross-react, but they shouldn't.
Yeah, I agree, Steve. I'm guessing that may have been what the comment or the question was, because I have also been in recent conversations about this antigen question, and the same thing has been no. In fact, I saw it cited on the CDC, some FAQ that said no, it should not cross-react. So just jumping into more, will the state mandate staff to take the vaccine if they work in a facility? Also, no, the state and I believe government broadly cannot mandate vaccine for vaccines that are authorized under an EUA. That said, employers can mandate vaccines as a condition of employment. I have not heard of anybody doing that yet, but just making the distinction between employers and government.
There were some news articles about that, just so you know, and so we'll more to come on that. But the published news said employers could. Now that is, take it for news, not necessarily the truth.
No, employers can. I've seen that discussed in medical, law discussions. They can. Just making the distinction between employer and government. And if government is the employer and government is still government cannot. Yeah.
Right. My only issue would be whether that's true for an EUA, and I don't think that that's been actually legally.
I have seen that. No,
okay,
I have seen that specifically discussed for this one. Yep. So are there plans for vaccinating health profession students on patient-facing rotations, e.g. medical students, nursing, et cetera? Yes, they are squarely included in phase 1A, healthcare personnel. In acute care settings, they should be in the list right now. They should be included in facility-based vaccination efforts. So another one, maybe Peggy, about reactions. So do you have guidance regarding how to distinguish a delayed injection site reaction from a cellulitis requiring antibiotics? Some of these injection site reactions have been accompanied by fever, warmth, pain, and swelling. I've also heard of several personally that are several days out, even like a week out.
Yeah, the pictures I had were from 7 days out. Those are the ones that I actually sent to Peggy to review, and I'll let her talk about the differentiation.
So if you have immediate itching at the site within 4 hours of your dose, you would possibly fall into that early allergy group that should see an allergist before getting a second dose. Otherwise, these delayed reactions are expected, probably normal, a response to this, but we are obviously awaiting more data and not a contraindication to getting the vaccine again. I saw a question about doing it in the other arm. I'm not sure. I think people could do it in either arm. So no data on that.
What about the distinction, though? This question specifically is versus cellulitis. How, in terms of making the distinction, how you judge, you make a decision about antibiotics or not?
I suspect that most of these are local reactions. It would be very unlikely to get an infection at that site. I have not seen any reports of that happening with other vaccines. Dr. Sears, you might be able to speak to that, but I bet these are not cellulitis. I bet these are just good, vigorous responses with fever and the whole works, and a good omen for a good response to that vaccine as well.
Yeah, I think cellulitis would be very uncommon. We have talked about putting some cold compresses, and you can consider localized topical steroids, not oral steroids. We've talked about trying to avoid steroids before, but as I said, it is described in the New England Journal article. If you sort of look under the adverse effects, under the safety side of the Moderna vaccine.
Great. So time for just a couple more at 7:58. Folks do have to sign off. Just remember, we are holding these twice a week, Tuesdays at 7:30 and Fridays at 12 noon. We'll be repeating some of the content here, but always time for more questions. How soon after recovering from COVID vaccine should someone get vaccinated? I believe we've seen pretty clearly after the isolation period ends. Anytime after that is okay. Anybody want to disagree with that? Frontline essential workers is broad. Are there criteria for which groups in which order? Not really, no. So 1B right now is frontline essential workers. And again, I think there will be more communications coming from the state this week about next phase of vaccine, but by ACIP, that's not really broken down further, nor the state, at least as yet. We're seeing we're also a provider congregating adults, vaccine clinics, Walgreens. Again, sorry, I do not have more information on the whole Walgreens thing. You know what, I will follow up and try to get somebody on the Friday call, maybe who can either give a little more answer or direction on that. Patients stating the second dose leaves them feeling sick for several days. Is that what you're discovering?
Yes, if people are going to have a reaction, they may feel kind of, well, I'll put parentheses around a medical term, yucky, for a couple of days, but that really might include low-grade fever. That was described in about 15% of younger adults with the second dose, aches and pains, and I have heard that, but some people have the second dose and just say, oof, that's it, done, and not had much in the way of those sorts of adverse effects. But if you're going to see it, it's going to be the second dose, much more likely, up to 3 days, usually, as I said, about 24 to 36 hours.
Okay, and we are 8 o'clock. I do see one question, and there's more. I'm sorry, we're not going to be able to get to everybody. But just a reminder, if you are looking for CME, we've changed the process, so you would need to send an email to covidcme.dhhs@maine.gov. It's also a question, do you recommend sharing the CDC link, I guess, to these recorded meetings with your patients and clients? I'd say it's up to you. I mean, these sessions are meant for clinicians. I don't know. It seems like they might be a little bit too technical for patients, but they're certainly out there in the publics and could be accessed. So, all right. So thank you all for joining. Thanks so much to all of our faculty group and Laura for joining us for this. Sorry to put you in a short time frame, but we really appreciate everybody's efforts, and we will be back on Friday at noon. Thanks so much.